morning, everyone. Welcome to our breakfast at UMHealth. I'm Prof from Pediatric Department. I'm honored to be chairing the first presentation, and I'll be the moderator for first presentation. And it gives me a great honor to introduce the first speaker, Dr. Chuah from the Department of Pediatrics. Dr. Chuah received her undergraduate degree from UPM in 2003, and she became a pediatrician in 2013. And a year later, to join as a senior lecturer as a pediatrician, and started working in pediatric ICU since 2014. And since then, she's been in pediatric ICU. And last year, we went to Tokyo in National Center of Child Health and Development, and she had a scholarship and gained some further pediatric ICU experience there, and working in a center that is established liver transplant for children, and she have learned quite a bit from that center. And this morning, her topic is on infection post-pediatric liver transplant in pediatric ICU. And without further ado, we just welcome Dr. Chuah. The floor is yours.
Thank you, Prof. for the kind introductions. Good morning, everyone. So I shall share the slide now. So today I'm going to talk about the infections post-pediatric liver transplantations in PICU. So the infections is mainly focused in PICU. So what I'm going to talk about, this is the overview. I'm going through a general introductions followed by my experience in Japan, and then how about our stance, and from all this experience, what is the learning points, and followed by a simple summary. So infections after pediatric liver transplantations has been an issue. It has been reported that this infections, the incidence infections is between 40 to 60% in the first 2 weeks, and followed that it will decline, and is expected to increase again 1 year later. So why we say that these infections after liver transplant is very important, because it actually determines the success of the liver transplantations. And we could see that despite of the improvements of all the immunosuppressive agents, surgical techniques, even though the ICU post-operative care, the incidence of the infections remain high. We cannot completely abolish this kind of infections post-liver transplant, post-transplantations. So liver transplantations is a life savings, and for several conditions, whether acute or chronic liver failure, or sometimes it do helpful for those conditions, metabolic disorder or hepatoblastoma. So you could see that then most of the focus of the report on the infections after liver transplantations in more on the overall infections incidence or infection rates, and we do not see much of the focus in PICU settings, despite that about 90% of the infections happens in the 90% of first month's infections happen in PICU. So back to the early 21st centuries, French centers reported that actually the infection rates after liver transplantation in PICU can be as high as 70%. And how about the mortality? So I think there's a very good center in the recent studies. They quoted that their center's mortality rates for early infections is as low as 3%, sorry. So, and we also find out that the more severe the infections, the higher risk of mortality. So we can see the impact on infections after liver transplantations. So how about Malaysia? What is our experience on the infections, pediatrics after pediatric liver transplantations? Our colleague Kam actually has made a historical review on hospitals Selayang's from the 2002 to 2015. She shared about the experience of the liver transplantation. The incidence of early onset infections is quoted as high as near to 70%. All these 38 patients, 42 episodes of infections. As reported, this bacterial infections is still the highest in prevalence. This is similar as others general studies, and they reported that CAM reported that Acinetobacter, Baumannii, and also Klebsiella pneumonia are the most common bacterial infections, and the commonest source of infection is abdominal drain and septicemia. So among all the mortalities, sepsis contribute to 40% of the mortality. So I think we have about the infections post-liver transplantations as in Malaysia's in more on the general overview. Then, but there has not been a report on the infections in the PICU. So as Professor Gans mentioned before, that actually I recently has gone to Tokyo National Center of Child Health and Development for a year for trainings in the PICU. So fortunate enough that we have opportunities to review their infections post liver transplantation in their PICU. So this is their PICU in NCCHD in short. And NCCHD actually is a liver transplantation center. Mainly is a pediatric liver transplantation. But they do occasionally 1 or 2 kind of adult liver transplantations. They started the liver transplantation service much earlier in 2005, and they performed pediatric liver transplantations about 50 to 60 yearly. They also do services in managing and stabilizing acute liver failure for transplantations. So in Japan, mainly about 80% are living donor liver transplantations. So now we're going to go through the infections post liver transplantation in the Japanese PICU. So the study have done is mainly to look into the pattern of infections post liver transplantations in PICU, and also looking into to the associated risk factors. So managed to review 3 years records, enroll about 150 patients. So from all this, we can see that about 2/3 of patients has was suspected infections, has a infection workup done, and then out of 1/3 of the suspected infections has a confirmed infection. So this is a general overview and the demographic data. So more than 50% of the patients are less than 1 year old. And there's equal distributions of gender for male and female. And they do more on the liver transplantations for chronic liver failure, specifically on biliary atresia. And they do offer liver transplantations for metabolic disorder, hepatoblastoma, and some liver tumor, acute liver failure too. So you could see that from here, the demographic data between those confirmed infection and without infections, there's no difference between them statistically. Next, we come to the timing of the infections. So the timing of infections reported in Japan is quite different from the Western cohort. From the literature review, Western cohort has reported that the infections peak at the second week, and then it would decline after the second week. So in Japan, the infection rate is highest, is in between day 6 to day 11 post-operative day, and they have another peak again 2 weeks POD post-operative day 2 weeks. So about the site infections, I think they also have quite high incidence of intra-abdominal infections, as high as 40%, followed by bloodstream infections, 21%. So about the risk factors, we could see that there's 2 reported risk factors for multiple regressions analysis. Re-laparotomy after post-liver transplantations for whichever reason, bleedings or any vessels thrombosis, they have about 7 times higher risk of the infections. And GRWR, graft to recipient weight ratio. So the higher is that, then the higher risk of the infections. Once the GRWR more than 3.5, the risk of infections actually is 8 times higher. So then how about the outcome? So they actually have an outcome which is relatively, I think, better than the reported in other centers. The mortality rate is 2 out of 150. So it comes to about 1% also. And the admission days is not shorter than other studies. Median about 12 days. So those with infection are 22 days, and without infections shorter 9 days. So mechanical ventilation days, they have a shorter mechanical ventilation days. General's median days is 1 day, and those with infections is 2.5 days. So then next come to how about in our center? We have started liver transplantations way later than NCCHD. We started with I remember the first one is in 2017 with a patient with acute liver failure. And then it stopped quite about 2 years, and we restarted back again with the regular pediatric liver transplantation service in 2019. All were living donor liver transplantations. In general, we perform about 4 to 8 cases per year. And we do offer intensive care service for acute liver failure, managements and stabilizations prior to liver transplantations. So how about the demographic data in our center? We have a total of total of number of patients of 21 liver transplantations from 2017 now. And I think there is not much a difference in between confirmed infections and no infections group, except for the gender, in which that you could see that those male patients, boy has a higher number of them had confirmed infections. Another thing is many our patient cohort is between 1 to 6 years old. We don't do, so far we have not been doing liver transplantations specifically on metabolic disorder or hepatoblastoma. And so far, what we have been doing is majorities for chronic liver failure, predominantly biliary atresia, and we have a quite number of acute liver failures, liver transplantation. So timing infections in our center also different from the Western country and also in Japan. Ours one is in the first week. Earlier is between day 3 to day 7. So 60% of the patients have infection in between this period of time. So site infections, intra-abdominal infections is similar as other reports, has a higher incidence. And beside from that, we have exceptionally high incidence of VAP and pneumonia at the same time. VAP is a ventilator-associated pneumonia. So how about the risk factors for the infections? So you could see that and from the analysis, found that a male boy has about 17% higher risk of getting some infections in our cohorts. So now come to the outcome. So so far we have 7 deaths, 7 mortality out of 21. So it comes to about 30% of the mortalities. And our PICU admission stays for those with a confirmation 24 and without infections is 12 for the median days. And we have a longer ventilation stays, 4 for those confirmed infections. Without infections, I think quite standard about a day as a median. So next, we're going to come to the comparisons between centers. You could see that the our incidence and infections in between the comparisons for the 3 centers. The earlier the local centers reported as high as about 70%. We are about 60. And Japan's the reported fairly low, it's about 20%. I think our sense is we are still within the range of 40 to 60% as reported in the review articles. So and then so now we are going through the difference in between Japan and to our center. So we could see that Japan's the patients cohorts mainly is for those less than 60%, less than 1 year old. And for us, ours one is mainly on in between 1 to 6 years old. And I think so. The other settings are quite similar in the way that we are doing liver transplantations, both of chronic liver failure. About 20% of the acute liver failure and female-male ratios are not much a difference. But we do not we offer liver transplantations for less diversity of liver diseases. So now we come to the infection patterns and the outcome. Okay, so we could see that we have a quite difference in terms for the pattern infection, except for intra-abdominal infections has the highest incidence for the site infections. So in Japan, they have 2 peak infections. So it's end of first week and also after second week. In our centers, we encounter infection happen much earlier in the first week, in middle of the first week. And site infections, beside from intra-abdominal infections, has the highest incidence. We have more ventilator-associated pneumonia compared to Japan. They have very few of those pneumonia and VAP. And about the percentage or incidence of the intra-abdominal infections, Japan's they quoted about 40% of the incidence. We are slightly lower, about 24%. And of course, from as I mentioned before, they have the outcome is good in the way that they have a mortality about 1.3%, relatively compared to ours, the 3%. They have shorter ventilator days and shorter PICU stay. The associated risk factors in our centers, we generate the similarity between the associated risk factors for both centers are, we found that actually is more to the non-modifiable factors for the ICU settings as a risk factors, like in UMCs, meal is a risk factors, and whereas in Japan, they found that the GRWR and re-laparotomy is associated risk factors. Other than that, I think preoperative infection risk, postoperative infection risk from the analysis, statistic analysis, we found that there's no difference in between the infections and no infection group. So we're coming to the learning points. So by looking at the outcome of the good outcome from the Japan Center, so then and the cohort of patients, then it come to the kind of thinking that it's probably that better to perform the liver transplantations at the earlier age before the late decompensated liver failure. But however, from our experience, performing liver transplantations of those smaller and younger patients, we are still facing a lot of challenges to overcome medically, surgically. And the timing infections, you can see that from Japan to ours and the Western countries, the timing infections vary center to center. This is probably related to the patient cohort and also the managements. Intra-abdominal infections, in general, is still reported the most common type of infections. And other than that, notice that there's a very low incidence of VAP or pneumonia and CCHD. This one probably restricted to their very short duration of mechanical ventilation. So conclusions. From all the review, from the Japan's data and our data. So at the points of intensive care point of view, patients' preoperative status, like a preoperative infections status and immune status, post-operative invasive monitorings and treatment care were not associated with post-liver transplantations infection. Okay, that's the end of the presentations.
Thank you, Dr. Chuah, for the excellent presentation. And you have shared the experience that they had and review the result of Japan and compare to our local data. From the chat box, we have 2 questions so far. The first question comes from Dr. Teh Sukun from Paediatric Department. Her question is about whether underlying cause for liver transplantation we have effect on the infection rate. That's number 1. And the second question is talking about we are not doing any transplantation for metabolic cause. And what about in Japan? What's the experience that they had there?
Oh, yeah. Thank you very much, Dr. Teh, for the questions. About the underlying cause for liver transplantations, whether it affects the infections, post-operative infection rates. Statistically, I did not look into it, and also from literature wise, I do not find very informative information too. But it's a good idea for us look into it in the futures if we have more cases on that, and then we should do a comparisons on this. Other than that, from the clinical experience, what I have in Japan, so relatively, those patients with metabolic disorder, their post-operative days in PICUs very short, compared to those acute liver failure or chronic liver failure with complications. The challenges in managing the patients with a metabolic disorder, I could see more on pre-operative and also intra-operative. I've seen a few cases pre-operatively when the patient admitted for elective liver transplantations and they decompensated. So the liver transplantations kind of do postponing the dates for the stabilizations, or sometimes they develop acute metabolic crisis during induction. So that one is a challenges for the anesthetist. So that is a challenges, but in PICU, say I don't see much complications compared to other type of liver diseases. And about the second question is, okay, the experience of liver transplantations in metabolic patients. Besides what I've mentioned, in Japan, they do liver transplantations mainly on urocycle defects and also some mitochondrial disease. I think so for urocycle defects, as far as I understand that its indication comes when they have a frequent acute metabolic crisis, and then liver transplantation is indicated when a frequent metabolic decompensation despite our adequate medical treatments. So, but the ultimate outcomes is most of the times is not complete curative, but kind of stabilizations prevents frequent metabolic decompensations. The second indications that we're seeing over there is those mitochondrial disorder. I think there's quite a lot of debates on performing mitochondrial disorders, liver transplantation of mitochondrial disorder. In Japan, for them, their focus in improve or quality of life. So they do liver transplantations for mitochondrial disorder, even though there's a neurological involvement. I mean, it's not. I mean, they do liver transplantations for mitochondrial disorder if there's extra hepatic involvement. So I think that's a quite controversial, and also look at our support, whether we could offer this kind of service. For our experience, we have one Wilson's disease, which is actually presented as acute liver failure and transplanted, and later on we found that this patient has Wilson's disease. In our centers, that is the only I think the only metabolic disorders liver transplantations that we have performed so far.
So then another question in the Q&A box asks about the empirical antibiotic, whether it affect the post-op infection rate.
Okay, about this empirical antibiotics, I think for most of the liver transplantations center, they will offer empirical antibiotics pre-operatively and post-operative, I mean, extend to the post-operative period and depends on the guidelines. Japan, they do so, and in our center, we also offer. But however, from say reviews, it's kind of saying that it is not effectively reduce the infections post-operatively.
There's a next question from Prof. Azana. You mentioned about transplantation is done earlier in Japan, and what make them able to do so, and why are we doing a bit late in our center?
I think if you would have the liver transplantation, I think the important part is the teams, which is must include, beside from the PICU team, we must have a trained anesthetists, trained surgeons who can perform liver transplantations. I think in our centers, the adult liver transplantation started much earlier than the pediatrics. I think it's kind of the availability of the expertise in performing pediatrics liver transplantations. It's not overall easily found in Malaysia. Yeah.
Yeah,
I think very few surgeons do pediatric liver transplantation.
Yeah, there's an answer from Prof. Serene, and she's one of the surgeon in the team, and she said that honestly, from the team, her feedback is we are not technically skilled enough to do the small baby. Yeah, and another factor, another factor that you have not compared or mentioned is our operation time is much longer as compared to overseas. Could that actually affect the infection rate?
From the analysis of the data separately, I didn't combine it for both centers. So the operative times is not kind of associated risk factors for two separate centers, because ours, as Prof. Gan mentions, our operative time is relatively longer than the Japan. So there's 7 to 8 hours complete operations. So most of the times go in 8 a.m. will be out at 4 p.m. So the operative times are relatively short, and I think the answer will come. So if let's say I combine both data together. So from the clinical experience point of view, from operation time. So I think the operation time does affect the stability of the patients. And in Japan's with the shorter operation times, I have never seen a patient with SIRS, hypotension, post-operatively. I only have seen one in which they have complications, and they track the operation times is near to 11 hours. Then that patient come in with hypotension and SIRS effects. As for us, once we encounter a lot of SIRS effects post-operatively.
Okay, that ends our pediatric session. Thank you, Dr. Chuah, for the excellent presentation. I'll hand over to Prof. Jayanti for the ENT presentation. Thank you.
Okay, thank you.